Good evening. My name is, this is New and Emerging Biologic Agents in CRS with Nasal Polyps, Pathophysiology Insights, and Patient Selection Criteria. My name is Tara Carr. I'm an Associate Professor of Medicine at the University of Arizona in Tucson. My disclosures are shown here. We have 3 learning objectives this evening. The first is to review the pathophysiologic and immunogenic molecular drivers of chronic rhinosinusitis, or CRS, that lead to the inflammatory endotypes and relevant comorbidities frequently observed in patients with CRS with nasal polyps. We will discuss the treatment differences between currently approved and emerging biologic treatment options for CRS with nasal polyps using data from clinical trials and other analyses. We'll incorporate an individualized, patient-centric focus based on consensus criteria for patients with CRS with nasal polyps when recommending a biologic therapy or endoscopic sinus surgery. So we're going to start with some pretest polling, and we're going to go ahead and open up the first question here, and you can go ahead and click on the button, and then don't forget to hit the submit at the bottom. So nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? Is it interferon gamma and TNF alpha, IL-1 and IL-6, IL-4, IL-5, and IL-13, or IL-12, IL-17, and IL-33? Go ahead, select one and hit the submit button at the bottom. Okay, we can move to the next question. While typically predominant in half of patients with CRS without nasal polyps, which of these cells are thought to also play a role in patients with severe type 2 CRS with nasal polyps? Is it eosinophils, neutrophils, CD8 positive T cells, or Th1 cells? I'll give you a minute to select your choice, and then you'll hit the submit button at the bottom. All right, we can move on to the next question. All right. A 39-year-old woman presents with nasal polyps and a history of moderate asthma. Her blood eosinophil level is 302 cells per microliter, and her total serum IgE is 25. Which biologic would be most appropriate? Would you consider mepolizumab, omalizumab, reslizumab, or tezepelumab for this patient? Okay, great. And then next. Okay, perfect. Thank you. A 49-year-old man with severe CRS with nasal polyps is placed on a biologic for those nasal polyps. When should he be first reassessed for response to treatment per the Euphoria guidelines and the multidisciplinary consensus algorithm? Should we reassess him within the first 6 months, at 6 months, between 6 and 9 months, or anytime after a year? Okay, everybody go ahead and hit submit, and we can move on. Okay, I think this is the last question. A 53-year-old man with severe CRS with nasal polyps presents for follow-up after 12 months on biologic therapy. Prior to starting the biologic, he underwent endoscopic sinus surgery twice with nasal polyp recurrence within 6 months each time. He currently shows inadequate response to the biologic per the Euphoria criteria and will not consider another surgery. What would be the most appropriate recommendation for this patient based on the Euphoria guidelines? Would you switch to a different biologic, continue the biologic for another 3 months, consider fluticasone intranasal spray, or stop the biologic and go back to medical management? All right, I think we can go to the next slide, please. Thank you so much. All right, well, we will cover all of those topics during the next 45 minutes or so, and we'll have a chance to redo the post-test and as a post-test and see how we do. Okay, so we're at the overview of chronic rhinosinusitis and chronic rhinosinusitis with nasal polyps. So chronic rhinosinusitis is quite a prevalent disease. It's estimated by the CDC that almost 29 million American adults have chronic rhinosinusitis. This represents about 11.6% of that total population. There are two major phenotypes, which are CRS with nasal polyps and CRS without nasal polyps. So with nasal polyps is the WNP, and the without nasal polyps is the SNP. So when we consider all patients with chronic rhinosinusitis, about 20% of those have nasal polyps. This is a little bit more male population, and about 80% have chronic sinusitis without nasal polyps, and this is a mostly female population. The disease burden for chronic rhinosinusitis is quite significant, and perhaps even more so for chronic rhinosinusitis with nasal polyps. These patients present with some characteristic symptoms of nasal obstruction or congestion, so the sense that they can't move air through their nose, usually because they have large polyps blocking that space, but sometimes also because their turbinates are swollen for other reasons. They can have extra secretion and feel postnasal drip from their nose. They can lose their sense of smell related to the polyps, and they can feel facial pain and pressure, particularly when their sinus cavities are involved. You can see images here. There's a CT scan on the lower left-hand corner of this slide, which shows a normal CT scan of the sinuses, which shows clear aerated sinuses with nice black space. And then compared with the sinusitis patient, where the sinus cavities are filled and the nasal cavity is filled with the polyp tissue. Patients who suffer from nasal polyps have impaired sleep quality because it's hard to breathe while they're sleeping. They feel more tired during the daytime and have a hard time focusing. There's a significant loss of workplace productivity. And patients who have nasal polyps may have embarrassment and loss of confidence, sometimes because they just can't smell and don't know if they smell bad or can't smell food, and just really have a hard time enjoying being around other people. On the bottom right-hand corner, we can see what nasal polyps would look like from an anterior rhinoscopy or endoscopy, a controlled middle turbinate on the left, and then you can see the shiny grape-like polyps filling up the nasal cavity next to that turbinate. The diagnostic criteria for chronic rhinosinusitis are shown here. So patients should experience these symptoms for at least 12 weeks or longer in order to consider it a chronic disorder. And they should have at least two symptoms of mucopurulent drainage out the front, down the back, or both. They should sense nasal congestion or obstruction. They may feel the facial pain, pressure, or fullness, and they can have a decreased sense of smell. These clinical criteria should be followed up with objective testing to confirm the diagnosis of nasal polyposis or chronic sinusitis, either by endoscopy to see that there's mucopurulent drainage coming out of one or more nasal sinus drainage tracts, mucosal edema related to that, or the formation of polyps. A sinus CT scan can also document inflammation of the paranasal sinuses and give a good sense of the extent of the disease. When we see patients who have chronic rhinosinusitis with nasal polyps, there's a set of standard of care medical management tools that we can reach to. There are intranasal corticosteroids, which are considered to be the first-line therapy. These are just the regular old nasal sprays. They're topical therapy. It's a non-systemic treatment, which has very few side effects. They're very well tolerated, although not that effective for treating nasal polyps. We do encourage patients to consider nasal saline irrigation, which is a low-risk procedure that reduces antigen load and mucus in the nasal and sinus cavities. And we usually recommend a large volume irrigation to really rinse out all the way to the back of the nose. Sometimes we can add steroids to those nasal irrigations to provide steroid therapy all through the nasal cavity and get some better penetration towards the back. But often we'll rely on courses of oral corticosteroids to give rapid relief of severe blockage, congestion, and loss of sense of smell for patients with polyps. This is a very widely used anti-inflammatory therapy. While it's generally helpful for our patients, there are some short-term side effects we need to be worried about, including increased rates of sepsis, thromboembolism, and fractures, and long-term increased risk of osteoporosis, cardiovascular disease, depression, anxiety, diabetes, and weight gain. So beyond the medical management, there are surgery and devices available as well. There's endoscopic sinus surgery, which is done by otolaryngologists and rhinology specialists, where it's through the nose into using tools to really kind of open up the sinus drainage tracts, debride mucosal inflammation, take away the polyps, and try to provide better topical therapy access. People feel better right away because their polyps are gone and their sinuses are open, but patients after surgery usually still need maintenance medical therapy to prevent nasal polyp regrowth, and we'll talk about that later. There's an option of the exhaled delivery system with fluticasone, or this EDS flu, which is an intranasal spray that delivers fluticasone, which is a topical steroid, but through this exhalational device. So you kind of blow the air into your sinus cavity, and it ultimately has better deposition throughout that sinus cavity, and that can reduce polyps better than the regular nasal sprays. And then finally, there's a steroid-eluting implantable stent that can be put in the ethmoid sinus tracts. It can be put in the frontal sinus tracts and can provide local steroid therapy and that sort of mechanical stenting to kind of open up the drainage tracts, maybe relieve some of the inflammation locally, and hopefully reduce the need for revision sinus surgery. So this is sort of a figure that shows the pathway many of our patients will take when they have chronic rhinosinusitis with nasal polyps. They'll be encouraged to use the nasal irrigation, intranasal corticosteroids, and occasional short-term bursts of oral corticosteroids. But for about 46% of patients in this cohort, they require surgery to control their disease. The medications just aren't doing enough to help keep their quality of life better. So after surgery, as we said, people feel better. Unfortunately, it's known that nasal polyps do recur after surgery for maybe a third of patients at 6 months, 40% of patients at 18 months. And some other data here showing that about a third of patients will require a repeat surgery and 12 years of follow-up of the first surgery. And about 20% of patients actually require multiple surgeries because their polyps recur after each intervention. So clearly, there's need here to do better for our patients. So let's talk a little bit about what drives chronic rhinosinusitis with nasal polyposis. What's the inflammation and immunology underlying this pathophysiology? So this is a representation on the left of what a healthy sinus and nasal epithelium should look like. You can see at the 12 o'clock on this little circle that there's sort of normal ciliated mucosal epithelial cell. It's injured due to a trauma, chemical, pathogen, infection, and there's loss of integrity of that barrier. But in normal tissue, it kind of regrows. There's this epithelial mesenchymal transition where the cells are sort of regenerating and filling in. They migrate, proliferate, reaggregate, and then they differentiate out into those epithelial cells that are more normal, healthy, and ciliated again. They form those tight junctions, and then they become normal. Unfortunately, in patients who have chronic rhinosinusitis, for reasons that aren't fully understood, an injury really doesn't ever heal properly. Instead of having the normal epithelial mesenchymal transition, there's development of acanthosis, so basically unhealthy cell proliferation, acantholysis, the cells don't actually connect back to each other, a secondary repair mechanism, and the cells never quite return back to normal. The cilia aren't necessarily highly functional, the tight junctions aren't necessarily highly functional, and so this patient is then susceptible to future injury, trauma, or pathogen. When we think about what's been seen in chronic rhinosinusitis tissue from biopsies from different types of nasal sampling, there really seem to be three different types of inflammation that we see, or called endotypes of inflammation. The biggest endotype that we like to talk about is what's called type 2 inflammation, which is characterized by helper type 2 cells and innate type 2 cells that release cytokines and recruit other cells and chemicals. So Alternatively, activated macrophages, eosinophils, basophils, and mast cells can all be involved in this type 2 response. The primary cytokines released by the Th2 cells and the ILC2 cells, as well as mast cells, eosinophils, and others, include IL-4, IL-5, and IL-13. These are considered to be the type 2 cytokines. And this type 2 inflammation is often seen in nasal polyposis. It's also seen in asthma, which can be comorbid to nasal polyps. And we believe that it's related to the loss of sense of smell for patients. There are a couple of non-type 2 forms of inflammation. One that we kind of generally refer to as type 1 inflammation, which is that normal response to an infection or injury, where you have helper type 1 T cells, or you have CD8 T cells that can directly kill things, M1 macrophages, natural killer cells. These cells release interferon gamma and IL-12, which can feed forward kind of an anti-infective pathology, but this contributes to the purulent nasal drainage when it goes unchecked. And then this type 3 inflammation, which is another form of non-type 2 inflammation, is characterized by IL-17 and IL-22 being released from T helper 17 cells. And there's lots of neutrophilic response for patients who have these cells, and that also contributes to purulent nasal drainage. So how does all this kind of come together and cause disease in chronic rhinosinusitis with nasal polyps? Well, on the left, we see a representation of that epithelial barrier that's in the nose and in the sinuses really becoming disrupted, whether it's an allergen, an infection, colonization, and by some bacteria, or release of toxins by bacteria like Staph aureus. And the epithelium, when it's being disrupted and damaged, releases chemicals called alarmins, which basically tell the immune system to start doing something. And these alarmins, TSLP, IL-25, and IL-33, tend to recruit the type 2 cells and cause type 2 inflammation. So on the top here, you have that classic allergy pathway that we think about in environmental allergies, but that can be present in nasal polyps, both due to pollens, pets, molds, things in the environment, but also to Staph aureus superantigen that can be present in the nasal cavity. And these things cause IgE that's sitting on the mast cell to degranulate those mast cells, which contributes to the inflammation locally. The IL-5 that's present recruits eosinophils, allows them to differentiate and survive for longer. They traffic into the tissues and can promote inflammation locally in the tissues. And then finally, the IL-13 is known to induce epithelial cells to make more mucus and to grow more goblet cells that then can make more mucus, and can also contribute to some of the remodeling through inducing fibroblast-related collagen production. And so those polyps begin to form and cause that space-forming mass. When we think about nasal polyps and we think about chronic rhinosinusitis without nasal polyps, usually we think about they having different inflammation. So it's generally thought that chronic rhinosinusitis without nasal polyps is more of a type 1, type 3, so non-type 2 inflammation. And we generally think of nasal polyps as having a more type 2 inflammation. But the truth is that there's overlap in this. And whereas neutrophils are very often seen in chronic rhinosinusitis without nasal polyps, about half of those patients also have eosinophils or some evidence of type 2 inflammation. Similarly, patients who have nasal polyps, although most of them have that eosinophilic type 2 inflammation, about a quarter of them also have neutrophils. This is a figure showing how complicated this mixed inflammation can become in type 2 nasal polyposis, where the eosinophilic pathways contribute to inflammation, contribute to damage of the tissue, contribute to the host immune response. And then on the right side, where the neutrophils kind of do the same thing. And it's interesting to see how the eosinophils and the neutrophils kind of have the same mechanisms of releasing what's called extracellular traps, which are little sort of DNA traps that are supposed to fight infection locally. And they release chemicals, cytokines that drive in other cells and contribute to the local damage of the disease. Okay, so we're going to have a couple of case studies, which will help us to formulate our thinking when we come to treating patients with chronic rhinosinusitis. The first patient we're seeing in our clinic is Angela. She's 41 years old, and she was diagnosed with nasal polyps 2 years ago. A year ago, she underwent endoscopic sinus surgery, but unfortunately, her nasal polyps have returned. She's had some evaluation of her sort of airway disease. She's had allergy skin testing, which was negative for environmental allergens. She does have a history of asthma. It was diagnosed when she was 25 years old. And her asthma evaluation has shown that she has 600 blood eosinophils, total IgE level of 25, which is consistent, which is low, consistent with not having allergy. And her FEV1 is 70%. So I think for this case study, one thing that we want to point out is that she's really experienced surgical management limitations from the standard of care surgery. So she had the surgery and her polyps grew back. And like we said before, in the short term, a big chunk of patients will see polyp regrowth, and sometimes it's very minor, but sometimes it's enough to bring back all of those symptoms and does require intervention, such as potentially a repeat sinus surgery. Our second case study is Jason. He's 50 years old. He was diagnosed with nasal polyps 4 years ago. He does have a history of allergies since childhood. He's allergic to dust and to cat dander. He hopefully doesn't have a cat, but we don't know that for sure. His blood eosinophil levels 225, so also a little bit on the higher side. His total IgE level is 150, and his FEV1 is also 70 because he also has asthma. He has been using medical therapy, and he says, I've been doing this nasal spray, the nasal steroid, and it's just not working that well. His polyps are growing. He's having a harder time breathing. He's lost his sense of smell, and he's looking for better treatment. He has tried saline irrigation, but he can't tolerate it because he's feeling increased air pressure related to the enlarging nasal polyps. He's been treated with 3 bursts of oral steroids and antibiotics over the last 2 years to try to control his symptoms, and that just hasn't given him a sense of relief. And he's willing to consider anything to get rid of his nasal polyps. So this patient really has failed standard of care medical management. The intranasal corticosteroids that he's used aren't helping him, probably because they're just mostly spraying at the front of the nose. They're not really getting into the sinus cavity where it's going to help his inflammation. The saline irrigation is not getting to where it needs to go, and it's not relieving any symptoms because he doesn't have enough space in his nose for the saline irrigation to really flush through. And the oral corticosteroids, although they can be temporarily beneficial and relieve symptoms, over time, accumulated steroid use, especially systemic steroid use, can contribute to side effects. So let's kind of hit the highlights here of the biologics, which are really the immunologic-based interventions for patients with nasal polyps. As of right now, there are 3 biologics that are FDA approved for treatment of nasal polyps, and they're listed here in the order of which they were approved by the FDA. The first is called Dupilumab, or Dupixent. Dupilumab targets the IL-4 receptor alpha chain, which is also used for IL-13 signaling. So it blocks both of those chemical signaling. It was approved for use in nasal polyps in June of 2019 for add-on maintenance for adults with uncontrolled nasal polyps. This is subcutaneously injected at a dose of 300 milligrams every 2 weeks. And there are 2 phase 3 studies that we'll review briefly, which support the use of this medication. Omalizumab is an anti-IgE antibody, which was approved in December of 2020 for nasal polyps as add-on maintenance for adults with inadequate response to intranasal corticosteroids. This medication is dosed based on serum IgE level and body mass index. So the dosing ranges between 75 milligrams and 600 milligrams every 2 to 4 weeks. And we'll review the Polyp 1 and Polyp 2 studies. And then finally, Mepolizumab, which is an antibody against IL-5, and so essentially neutralizes IL-5 and prevents IL-5 from signaling, was approved in July of 2021 for add-on maintenance for adults with inadequate response to intranasal corticosteroids. This is dosed subcutaneously 100 milligrams every 4 weeks, and as shown as the Synapse study. So first we'll look at Dupilumab. So these are the kind of main outcome tables here of Dupilumab in the 2 different studies. One study was the Sinus 24, where patients were treated for 24 weeks, either on placebo or drug. And then the patients who were receiving treatment actually came off of it, and they were continued to be followed for another few weeks. The Sinus 52, they were randomized to either treatment or placebo and monitored for 52 weeks. The top two charts show those two different studies. I think you can appreciate that the nasal polyp score, which is essentially how big the polyps are, the polyps shrank by a score of 2, which is pretty clinically significant. And you can see that after 6 months of treatment, when patients came off of treatment, their polyps started to grow back again. It's not known what would happen after a longer period of time at this time. Patients who were on treatment also did feel better in terms of their nasal congestion or obstruction scores, which, again, is very important for patients who feel bad because of their polyps. One other important outcome for our polyp patients, as we talked about earlier, is reducing the need for oral corticosteroids or preventing patients from having to go back to surgery. And you can see here that in a pooled analysis of patients, the hazard ratio for needing steroids or surgery was much lower in patients who were on treatment than patients who were on placebo. Of course, safety is something that's always monitored in these studies, and you can see here that there were some treatment-related adverse events noted, with more serious treatment-related adverse events in the placebo group as compared with the Dupilumab arm. And the major side effects people reported were nasopharyngitis, and then more often in the placebo group was nasal polyps worsening. This is a figure showing the change in nasal polyp score for patients on Omalizumab in the Polyp 1 and Polyp 2 studies, shown in the orange lines, with the placebo shown in the gray. And you can see that the nasal polyp score improved by about 1 to 1.25 in each of these studies. And this was given for 24 weeks, similar to the Dupixent. And then this is the slide showing the nasal congestion outcomes for patients, again, showing an improvement from the baseline and nasal congestion score for patients who are on treatment compared with those on placebo. And then the safety data, total number of treatment-related adverse events was low in this study. Serious events were low as well, with the most common problems being asthma exacerbation in the placebo group, nasopharyngitis in the placebo group more so than in the Omalizumab group, and some headache reported in the Omalizumab group. And then these are data showing the Synapse study for mepolizumab. On the left is the nasal polyp score data, and on the right is the visual analog score for improvement in nasal obstruction. So on the left, you can see that there were the treatment group is on the blue on the top, and the placebo group is on the bottom in gray. And these are organized a little bit differently to show patients who are worsening over the course of the study, had no change, and then had different levels of improvement. So you can see that there's more blue on the side that improved, and so more people had improvement in their nasal polyp score on treatment than on placebo. Similarly, there were a group of people who had a significant improvement in their nasal obstruction score, more so than placebo. Mepolizumab, this study also looked at the reduction in the need for surgery in patients who are receiving therapy, and you can see the hazard ratio is 0.43 for, so it's much better in patients who are on treatment. And then the safety here, total number of treatment-related adverse events, a little bit higher in the mepolizumab group. The most common adverse events happening were nasopharyngitis and headache, with sinusitis more common in the placebo group. There are biologics being studied in advanced levels at phase 3 clinical trials for nasal polyps. One of these medications is called Benrylizumab, which is an IL-5 receptor alpha antibody, and so it kills eosinophils by blocking IL-5 receptor signaling and by inducing antibody-dependent cellular cytotoxicity. You can see the two studies that are ongoing here. This is also given subcutaneously. Tezepelumab, which is an anti-TSLP antibody, is being studied in severe CRS with nasal polyps and is also a subcutaneous injection. The Snot 22 score is a validated patient-reported outcome measure that shows a scale from 0 to 110 in 22 different domains of nasal symptoms, and it's very cutely named. It's the Sinonasal Outcome Test. So in the Snot 22 scores improved in all of the studies. You can see here comparing from baseline to treatment endpoint in the placebo and treatment groups. All of the biologics made people feel better, which is really important, I think, when you're taking care of patients and they can come tell you that they feel better. Okay, so how do we pick a treatment when we have all of these wonderful options? This is a multidisciplinary management algorithm for CRS with nasal polyps that was developed by a US group. And this really acknowledges that the majority of patients who are first diagnosed with nasal polyposis probably will end up getting sinus surgery. And it's really important to discuss what that sinus surgery means. And I think it's best if the surgeon is the person to do that because they can talk about all of the ins and outs of it. But when people have sinus surgery, they feel better right away. And not everybody has recurrence of their disease, especially if they're using postoperative management really regularly, including steroid irrigation, topical intranasal steroids, and potentially other options when symptoms arise. For people who undergo sinus surgery, if their symptoms recur or if they for some reason weren't improving, and they're using appropriate postoperative management, then there are other things you can offer the patient, such as biologics that we just talked about, particularly if patients have another comorbidity for which the biologic might be useful, such as asthma. Some patients undergo a revision sinus surgery, potentially to make it a little bit more open up more sinuses. Patients who have aspirin-exacerbated respiratory disease may undergo desensitization for aspirin, which is a specific intervention for those patients. Steroid sinus implants may be helpful for local treatment, and short bursts of oral corticosteroids to reduce inflammation can be helpful. For the minority of patients for whom surgery is not an option because they have a contraindication or can't for some other reason have surgery, particularly if they have poorly controlled asthma or if they're steroid dependent for their airway disease, then you might actually start a biologic first before surgery. And this would be either Dupilumab, Omalizumab, or Benrylizumab, and then sort of reassess. And if they're still symptomatic despite the biologic, reconsider whether surgery is still contraindicated and consider some of these other interventions to control their disease. Euphoria is the European Forum for Research and Education in Allergy and Airways Disease. The Euphoria group updated some recommendations for chronic rhinosinusitis with nasal polyps in 2021. They define uncontrolled nasal polyps as those that are persistent or recurring despite regular use of long-term intranasal corticosteroids, having a course of oral corticosteroids in the previous 2 years and or previous cytonasal surgery. So essentially, they're doing what they're supposed to do and their polyps are still there or have come back. Severe CRS nasal polyps is based on how big the nasal polyps are. So a 4 out of 8 nasal polyp score, meaning that the polyps are probably both at the level of the middle turbinate or below. And patients are having persistent symptoms despite long-term steroids and they need something more. The American Rhinological Society and the American College of Allergy, Asthma, and Immunology developed this project for shared decision-making for CRS with nasal polyps. This has not yet been really widely advertised, but it is available online. And if you're treating nasal polyps, you might want to look at this tool. It's kind of an interesting way to think through some of the options and to provide some education about those options, both for providers and for the patients. So per the Euphoria guidelines, selecting a biologic is something that we do hoping that we're right, but really without very specific guidelines about how to do this. So as you may have noticed when we were talking about these different biologics and their use in nasal polyps, people didn't need to have blood testing or other biopsy results or any other biomarkers of disease in order to get into the studies other than the fact that they have nasal polyps. This is different than asthma, for example, where biomarkers really are required to use some of these biologic therapies. So it's sort of all comers into the studies, and overall people got better, although of course there's going to be heterogeneity. So we can't really predict any response to therapy for each patient with each drug. When we are anticipating starting a biologic, one thing that's really important to do, of course, is to confirm that this is uncontrolled and severe, meaning that the polyps are big, the patient's bothered by them, and that they've been using appropriate medical therapy to try to control the disease. Sometimes it's helpful to check for comorbidities like asthma or environmental allergies, because treatment of those disorders may actually improve the way patients feel and their symptom control. And then it's really important just to talk to the patients about all the different interventions that are available, the different biologics, how they're dosed, how they work, what's known about them, how well they may shrink polyps, and then to make decision using a biologic or something else like surgery or a medical intervention using shared decision making for the patient. The Euphoria guidelines do recommend that for patients who have asthma, selecting a biologic in collaboration with the asthma specialist may actually be very helpful, because if you're using a drug that could help both the sinuses and the lungs at the same time, then the patient will benefit even more. So we're going to return to the case studies now. Angela is our 41-year-old who is not allergic. She's had polyps for a few years. She had surgery, and her polyps came back after surgery. And she also has asthma. So the question for her is, would we recommend revision surgery for her? Why or why not? Would she be a good candidate for a biologic? And if so, what biologic would we recommend? And then how would we facilitate shared decision making with this patient? So, since I'm the only one that you guys can hear, I'll give you my opinion on this. Is that I think revision surgery, if the surgery was done well, if everything is as open as it needs to be to get good flushes and topical therapy in the nose, and if she's using those regularly and she's still having recurrence of polyps, and then I'm not sure I would send her for another surgery. I think this is somebody who would be appropriate to try a biologic for, and reassess at the appropriate time frame, which we'll talk about in a second. So with the biologics, Omalizumab actually does require an IgE 30 or greater for dosing. So her IgE level is 25. So technically she doesn't meet criteria for Omalizumab. So I think Dupilumab or Mepolizumab would be reasonable choices for her. What information would I give her to facilitate shared decision making? I think I would talk to her about my experience with the biologics, how they're dosed, how they get processed through insurance, what the potential side effects may be, and what she can expect with the treatment. Our second case study was Jason, who's 50. What tests? Remember, he does have allergy. He's a long-term allergy patient who also has asthma, and he's been using medical therapy and is just not doing well. What tests would I ask for? Well, like we said, we don't really do biomarkers necessarily, with the exception of the IgE level for Omalizumab, and he already had that, and he would fit in the range. I think if he hasn't had a good sinus CT scan to determine the extent of his disease, that would be reasonable. And I think he might be a good candidate for endoscopic sinus surgery, because he hasn't had one before. It would help clear him out, allow the topical therapies delivered. And I'd have him see one of our rhinology specialists to talk to him about that option. If for some reason he wasn't able to have surgery or didn't want to, we could consider using a biologic. And I think he would be a candidate for any of the biologics based on the labs that we've seen, but also because there aren't really other guidelines that are supporting it. He has environmental allergy, and we kind of think about that as benefiting from Omalizumab, which blocks IgE, which is allergy. But I think the reality is we don't really know. So Euphoria does recommend that when you start a patient on the therapy, you reassess. And this is obvious to some extent, but also really, really important, because we're putting people on interventions, these biologic medications, which are quite expensive. They're new, they're injections, they require repeated treatments. So I think it's appropriate to determine that a patient is actually benefiting from the medication that you're giving them. What we acknowledge is that it can take a while to see significant benefit from these medications. In the nasal polyps outcomes, you see the improvement in the nasal obstruction, improvement in the nasal polyp scores, kind of happening gradually over those first few months. So give it a few months to really know whether the medication is helping. Of course, if the patient's having issues with the medication, if they can't afford it, then you reassess sooner and consider other options. But if they're on the medicine, give it 6 months. At 6 months, see how the patient is doing. Ask them about their sense of smell. Ask them about their nasal symptoms. You can do a Snot 22. You can do a nasal congestion score. You can do an endoscopy or interior endoscopy and see if the polyps have improved significantly. The Euphoria guidelines suggest kind of objective cutoffs for some of these measurements, which may or may not be, easy to do in clinic if you're not used to doing these assessments. But the general overall gist is that the patient should be doing better in at least one of these domains, if not more. If they're not improving, then you should consider something different. Consider a different biologic, consider a revision surgery or a first surgery. If the patient is showing improvement and they're happy with the level of improvement, then you should continue the biologic. We don't yet know how long patients should be on these medications before we stop them. So as of right now, if they're doing well on them, we really keep it going. If the improvement is not acceptable to the patient, if they're a little bit better, but they're just not seeing a lot of improvement, you could consider giving a little steroid. You could consider doing a sinus surgery at that time to debulk whatever inflammation or mucosal tissue is present. And then you really have to talk to the patient about whether they want to continue with the biologic to give it a little bit more time or whether you need to switch to something different. After 12 months of treatment, Euphoria gives us a pretty strict level of benefit that they'd like to see in order to consider somebody's response adequate to the biologic. So they'd like to see a nasal polyp score of less than 4. So that means that the polyps are smaller than to the level of the middle meatus. Their nasal congestion score is low. Their total symptom score is low. Their Snot 22 score is low. And they're not needing surgery and they're not needing systemic oral corticosteroids for the symptoms that they may have. Euphoria suggests that if the patients meet these criteria, then they continue their therapy. And if they don't, then it might be time to consider another biologic or another surgery. My sideline would be that sometimes people don't meet all of these definitions, but are perfectly happy with how they're doing. And for those patients, I feel comfortable continuing their biologic therapy. We touched a little bit on how to differentiate between the available biologics. And not only are there not clear indications of which patients should go on which treatment, but there's a lack of head-to-head clinical trials between those biologics for nasal polyps and for all of the other disorders that we use these to treat. So we're really going by doing the best we can with what we know about these medications. So again, to review, Dupilumab is an IL-4 receptor alpha antagonist that blocks both IL-4 and IL-13 signaling, which are key drivers of type 2 inflammation, which we know contributes to the nasal polyps and symptoms of nasal polyps. Omalizumab is an anti-IgE antibody, which prevents IgE from binding to receptors on mast cells and basophils, and so they can't degranulate and release their inflammatory cytokines in response to either environmental allergen or local superantigen production. And then mepolizumab is an IL-5 antagonist, which binds to and inactivates IL-5, which is a key driver of inflammatory eosinophil differentiation and proliferation. So in summary, we do think that the understanding of the pathogenesis of chronic sinusitis has continued to increase in the recent years. The introduction of biologics in this clinical space has improved our understanding of the pathophysiology and management of nasal polyps, and it's giving us better options, which is really important. Treatment for nasal polyps should be based on the molecular drivers of inflammation, response to treatment, and patient preferences. And then hopefully with new and emerging treatment options for nasal polyps, the prevalence of severe and uncontrolled nasal polyps will diminish over time, and we'll be able to help more patients with the tools that we have available. So with that, we'll go to the post-test polling. And I invite you to answer these questions that we reviewed earlier, that nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? So is it TNF-alpha interferon gamma, IL-1, IL-6, IL-4, 5, and 13, or IL-12, 17, and 33? Okay. Well, this was kind of that classic type 2 inflammation that we talked about in one of the earlier slides, where there's the type 2 and then the non-type 2, and the type 2 being really prevalent in chronic sinusitis. So the IL-4, IL-5, and IL-13 are going to be driving the allergic inflammation, the eosinophils present in the tissue, and some of that increased mucus production and remodeling from IL-13. Okay, great. We can go to the next question. While typically predominant in 50% of patients without nasal polyps, which some of these cells are present also in severe type 2 nasal polyps. So this is, usually we see these in non-polyp disease, but sometimes we actually see them in severe nasal polyps. This is a little bit of a tricky question. All right. Well, I'm delighted to see that whereas nobody picked neutrophils on the pre-test, everybody seemed to pick it on the post-test. And so it's true that neutrophils are present in non-polyp disease and in a subset of patients who have severe nasal polyps. Great. Next question. Okay. So this is a 39-year-old woman with nasal polyps, moderate asthma, who has eosinophils of 302 and IgE of 25. Which biologic would be most appropriate? Remembering that for Xolair dosing, it has to be 30 or up. Okay, great. So everybody on the pretest selected Benrylizumab, which nobody selected now, which is great because we didn't really talk about that medication relevant to nasal polyps. The Tezepelumab is one that's in process and in phase 3 studies, and so we don't have that one available either. And so the real two differential choices are the Mepolizumab and the Omalizumab. And I think this question was really asking. Really, because the total IgE is a little bit lower and the eosinophils are a little bit higher. And so maybe you would choose the Mepolizumab for her instead of the Omalizumab for treatment. Although, again, we don't always know completely. I think because her total IgE is less than 30, it might be hard to get the insurance company to approve use of this medication. Next slide. Okay, a 49-year-old man with severe nasal polyps is on a biologic. When should he be first reassessed for response to treatment per the Euphoria algorithm? All right, great. Well, everybody who answered this question answered it correctly. So we do reassess at that 6-month time frame to make sure that the medicine has enough time to work, really. Or I guess sooner, as I said, if there are issues, concerns with the medication administration. Great. Next one. Okay, 53-year-old man with severe nasal polyps who's been on a biologic for 12 months. And prior to the biologic, he'd already had surgery twice. And his polyps came back both of those times. So he's had 2 surgeries and he's been on a biologic. And he's just not responding properly to the biologic, but he's not going to do surgery again. So based on the Euphoria guidelines, are we going to switch to a different biologic? Are we going to keep going with the same one? Are we going to try the nose spray? Or are we going to go back to medical management in general? All right, awesome. Looks like everybody has picked the switch to a different biologic option, which is the intended answer. So this patient, he's already had surgery. That's not an option for him. So we're looking at all the different medications, including biologics. And if he's failing this one and he's given it a long enough try, then try a different one, and let's see if that does the trick for him. Great. Next question. Oh, was that the last one? Oh, congratulations, everybody. You've finished your questions. Okay, well, we have some time here for the question and answer session. I believe you can enter questions into the chat function. I should be able to see those questions. I'll give you a couple of minutes to throw questions in there if you have them, and I'm happy to do my best to answer. So, question by Anonymous: how do you choose a biologic to first start a patient on? So it's a really great question, and I think it's a really hard question, and I'm happy to give you my opinion. I think so. All of the biologics are injections, so we have to really talk to our patients about the fact that it's an injection, and they're going to have to do that regularly. Here, where I practice in Arizona, the Dupilumab is administered at home only, which for some people is a really nice option because they don't have to come to the office for injections. For other people, that's like not really a great option for them. Omalizumab and Mepolizumab can both be administered either in the office or at home. And so sometimes that makes a little bit of a difference for the patient about what drug they'd like to try. Some patients have insurance limitations that will really kind of drive you towards picking one drug over the other. So of course, that's very, very important because with expensive medications like this, you want to make sure that it's covered by insurance. If they have comorbid asthma, we didn't talk a lot about how to select a biologic for somebody with asthma, but each of the different medications has cutoffs of eosinophil levels and allergy levels and other indicators that suggest a response to that medication, but also that are used by insurance companies to limit that. So if they have comorbid asthma that would potentially benefit from this treatment, I try to use that as a guider. We have the most experience using Dupilumab because it's been around the longest for treatment of nasal polyps. A lot of our patients are very happy on it. And so I'm happy to offer that. But I also do discuss the other options, the Omalizumab and the Mepolizumab, because I want our patients to know what the different treatments are. So really great question. Thank you so much for that. Are there any other questions? I'll give it a few more seconds. I'll wait to see if there's anybody typing. Okay, I'm not seeing any extra questions. So with that, I'll just go ahead and show you the final slide, which is the thank you slide. And we wanted to share that there are additional resources and information on nasal polyps at the Integrity Continuing Education website, which is shown here. We'd love for you to complete an evaluation and claim your CME credit at the link shown here, and you'll be automatically redirected once this presentation is over. So thank you very much for attending this evening and for your questions and for participation in the pretest and the post-test. I hope this has been very valuable for you.